hear from a provider. Erin Stucky is EVP of the KVC Health Systems, which is one of the lead agencies in Kansas. But she also, through her company, has been active in Nebraska. The experiences in the two states are pretty different. Kansas launched its privatization in the 90s and maintained the CPS work at the state level, as I understand, but privatized all of the foster care and other family services. They had started with 5 regions, but have moved to 4 regions. And so you do see change over time in how services are administered and the capacity for making those changes. Nebraska was a rather short-lived privatization effort that began in 2008 with the intention to expand the percentage of children receiving in-home community-based services from only 30% to 70%. But today, only the 2 counties that encompass Omaha are in a privatized system. So from her experience as a provider, we hope to learn what the opportunities and what the challenges are for us as we look at reforming the child welfare system.
Thank you for having me. I want to start by also thanking Casey. Casey has been involved in Kansas and has really, in the last number of years, helped really bring together this privatized in different regions state to work as a team and to still be focused on the state as a whole rather than focus on one contractor has one region and having that sort of tunnel vision on our own work and owning that. Casey has really helped us move past what really ends up being a competitive contract process and into prioritizing our whole population, which, you know, in this case is all of the children and families in Kansas. So my organization has years of experience with privatization in Kansas, starting from the very beginning. We have privatization experience in Nebraska. We also have operations in Kentucky. It's not a formally wholly privatized system, but we have contracts with the state for half of the counties in the state for family preservation services. So we have a private-public partnership there, but as it relates to family preservation. We also have services in West Virginia, Child Placing Agency, foster home services. I do want to say some of the things Lynn was saying in the beginning, I agree entirely with, and were among the things I put in my notes. The importance of having a shared vision. For any state or system looking to make reform, it's critical to have a shared vision about what are the indicators, what are the outcomes, and defining those clearly. Getting a baseline, knowing where you are now and how that's going and where you want to be to set the course. In Kansas, it was, I think, 1995, Governor Bill Graves was elected, and he came into the state reviewing all of the systems, what was happening, and he found that since 1989, the then agency was called Social and Rehabilitation Services, SRS. Since 1989, they'd been in a settlement agreement with a children's rights lawsuit. They had made almost no progress in the 6 years since the settlement agreement was initiated to settle over 100 elements of the agreement. So at that time, and each year from the settlement agreement, the legislature had put more money into the state system because the state leadership was saying, you know, caseloads are too high, we need to reduce those. So the legislator kept adding money. And the elements of the settlement agreement were not being achieved. So he made the decision, it was not a legislative decision, it was his decision to create privatization. He hired a previous legislator who had been very vocal about concerns about the system to come and lead the system. And so together they established an RFP that allowed anyone, well, it had to be a not-for-profit organization, to offer a bid to do this work. The state was in 5 regions. There were 3 contracts at the time. There was a family preservation contract, a contract that was for reintegration foster care, and then an adoption contract. 4-year contracts with and it's varied over time. 1 2-year renewal option, 2 2-year renewal options. But every 4 years since that time, there has been a new RFP issued, new bids go in, new proposals for how to get the work done. Each one of those contracts has had very clear outcomes and objectives and requirements. Some of them have been very prescriptive. Here are exactly the kinds of meetings you have to do and in exactly what kind of time frames. And some of the contracts have not been prescriptive at all. They have provided the indicators and provided some baseline and said, you tell us how it's going to happen. So KVC has had the contract since 1997, the very first one. It was a very swift implementation. Family preservation kicked off first, I think in late 1996. And then reintegration, foster care, and adoption started in 1997. Cases started transferring in March of 1997. By May, all cases, so all children involved in family preservation services, all children in out-of-home placement were transferred to the private providers in that 2 to 3 month period of time. And during that period of time, new referrals were coming in. Some of the difficulties of that transition in Kansas were that there wasn't a lot of good baseline data. There were outcomes that were defined in the very beginning, but when questions were asked, for example, X percentage of children need to be placed with siblings, X percent of children need to be placed in their home counties. When requests were made for, what is the baseline now, often the state's response would be no data available. And so that made it difficult to know from where we were starting. So that took time, and living in the middle of it, at the time I was a new staff in a new system, it made it difficult to know how to move ahead. We didn't know what worked and we didn't know where we were. Some of the things that did work, that kids were staying safe, even though it seemed chaotic to people who were watching, who looked in. They were seeing more cases come in than had been projected. They were seeing more children transferring than had been projected, but children were still remaining safe. There was a reduction in the use of congregate care. Private providers were paid. The other thing, I don't mean to keep jumping around, but there's so much to say. In 7 minutes it seems impossible, so when I think of something that seems important, the payment mechanism has changed with every contract too, and part of that has just been the willingness of the state leadership to be flexible with what they thought was going to work with that first contract. They felt over time wasn't working quite the same, so with the next contract they made changes. So with the first contract there was a 1 life case rate, and so providers had to make decisions about how to spend the funds. And so it was important to get children in the lowest level placements that would meet their needs. So children needed to be placed with families if family members could meet those needs. They only needed to be in congregate care settings if that was medically necessary, frankly. We looked at Medicaid guidelines for how to make that happen. So children were getting out of congregate care because they didn't need to be there. There were requirements related to caseload sizes. And so that was a positive change. There wasn't an option to overfill staff's caseloads because we had contractual requirements to meet. For the first time, there were clear objectives and outcomes that were to be met. In the initial contract, there were no financial penalties or incentives for achieving the outcomes. However, if they weren't being achieved, then there's no chance that we were going to be able to continue to partner and provide the service. It was important to the private providers to make sure that we were meeting outcomes, not just because we knew it was best for kids and families, but because we believed in the work that we were doing, and we believed in the outcomes that were established. Also, the private contract at the time really created flexibility for the private providers to make adjustments based on what they were seeing, based on new research that we were finding. We didn't have to wait for a new state policy. We didn't have to wait for a new legislative action. We can make decisions to make changes to our practice as long as we were still adhering to the requirements of the contract. Some of the things didn't work quite as well. When privatization was rolling out and when the idea came forth, there were some community forums. I was saying last night that I was a social work student at the time, and so, I was so passionate and I would go to all those forums, and man, I thought this was a horrific idea because this isn't where child welfare belongs. And that's what the community was really saying, and there was this momentum to fight it. And what we learned is that judges weren't being included. So thinking back, looking around these forums, there weren't judges there. There weren't legislators there. There were some stakeholders that were invited, but not necessarily engaged and pulled in the way that now looking back would have made much more sense, have them being a part of the development of the change, if really that was the change they were going toward. And so, with the judges in particular and the legislators not as involved and not on board, the perception, the anecdotal concerns that came out certainly became a barrier to getting the work done. And so now in Kansas, just quickly, there are 2 contracts. There's a family preservation contract, and there's a reintegration foster care adoption contract. The state realized, I think, 2 or 3 contracts in that separating adoption from reintegration foster care didn't make sense. Because what was happening is one provider was serving the child from the time he or she was removed, providing all of the services, partnering for services, but then when the case plan goal became adoption and the parents' rights were terminated, the child's case was transferred to a different organization. And so it caused delays. I think the idea was that having someone specialize in that and focus only on that could create more timely permanency for adoption, but that didn't turn out to be true. So now it's combined, and since July 2005, when KVC began, that adoption contract was rolled in, we finalized about 3,500 children's adoptions. So we have found that combining those was very helpful. Currently there are the 2 contracts. There are now 4 regions in the state instead of 5. KVC holds the contract for 2 of those 4 regions for both contracts. And one other organization holds the 2 contracts in the 2 other regions. So in Kansas now there are 2 private providers providing all services for children in family preservation and out-of-home care. Also, the contract in Kansas requires 1 year of aftercare services following permanency, following reintegration permanency. The current contract is a contract lifetime of aftercare for children whose adoptions are finalized. I will quickly also talk about Nebraska. Nebraska was also implemented fairly quickly, and it was also under the direction of the governor at the time. The goal was to improve CFSR outcomes, safety, permanency, and well-being. Sort of a cumulative overview of Nebraska as it stood compared to other states in the CFSR at the time is that they were about 48 out of 50 states. So the goal was to focus on permanency, safety, and well-being. Also, as mentioned, the goal was to serve more children in their home rather than serving them outside of their home. So that was really the mission of the private effort. Again, in Nebraska, some things that happened in the rollout was judges were involved. I actually went to a number of meetings where judges were engaged and asked about their feedback. The legislature, however, was not involved. And it was later very apparent the legislature was not on board. And so that caused a problem. When there were concerns with what was happening, they were very vocal, they were demanding answers, they wanted to know how decisions were made about the funding because they hadn't been involved. The funding in Nebraska was also an issue. It was originally, there were numbers of children and families to be served were provided. And then there was an all-in cost that would be provided to bidders. So a set amount and that was it. It was not going to be a case rate. So what happened is the bidders came in, contracts were awarded, and then more children were referred than had been projected. And then case management was not part of the contract at the time. And then shortly after contracts were signed, the state decided case management needed to be a part of that. And so then they added a one-time payment, but that payment didn't continue. So operating within the confines of a set amount of money with no ability to ask for more money, more funding, created some barriers. At the time, what was provided was that the state needed a year to 18 months to really gauge what was happening, how services were being provided, so that they even knew where to begin to establish a case rate. But what happened was the year came and went, 18 months came and went, and still no case rate was established. Also in Nebraska then, some of the things that went well originally is that there was immediate implementation of 24/7, 365 availability to children and families. That's not something that had happened before in Nebraska. Kids and families were served by state workers unless there was a per case referral to a private provider, but there was no systematic way of doing that. So some families got served by organizations that were available to them more often, but most were served by the state and they weren't available all hours. Caseloads also reduced with privatization based on requirements of the contract. Aftercare was also a part of the contract there, and actually we're the organization that recommended they build that into the contract because we saw the success in Kansas with building that into the contract meant keeping kids at home after they achieve permanency. Only about 3% of the children in Kansas become reentries after they achieve permanency. So that became part of the Nebraska contract. Also, we began to see a culture shift in Nebraska from the state makes a better parent. Children were getting removed so often because it sort of seemed to be believed that the state could take care of the kids better than their families. And so with the implementation of this privatization and the focus on serving kids in their homes, we saw that begin to shift. People began to see if you put services in the homes, children can remain there safely, and we can see that families really are the best parents for their children. Aside from the funding, I think the other thing that really didn't work in Nebraska had to do with the timelines. There were timelines established for making decisions, for implementing programs, for implementing rollout, and flexibility is critical. So if the state and the providers weren't ready, it made sense to change those, but there was no systematic way to do that. Negotiations would begin for case rates, but then they would stop, only to be picked up a month later. Within a year of the contract's beginning, which would have been in the fall of 2009, two of the private providers in one of the regions held by KVC, so there were 3 private providers in the region, 2 of them dropped out. So all of those staff and all of the children and families served by those other 2 were absorbed by our organization. And then in the other region, in which KVC held a contract, one of the providers dropped out as well. So increasing caseloads, increasing staff, continuing to have to build that infrastructure with no new mechanism of payment made it very difficult. And so in the fall of 2011, we continued to try to negotiate a case rate. We were losing so much money. And finally, in November of 2011, when an agreement couldn't be reached, we had to provide notice that we could no longer be a contractor. So at that time, the state eliminated the public-private partnership altogether, but maintained in the 2-county area covering Omaha what they still refer to as a pilot with Nebraska Families Collaborative. They continue to be the primary case management provider for the children in those 2 counties. We continue to have the child placing, we're the largest child placing agency, in fact, in Nebraska. We serve those children through a public-private partnership, but in a different way. We also contract with the Nebraska Families Collaborative to serve the kids. So I really just, again, I think the key in both states, certainly for us in Kansas, 17 years into this is the way it is for us. It makes sense. It works very well. Our outcomes are strong. We're working well. But I think it's about that shared vision, and it's about shared outcomes, shared indicators, shared responsibility for the whole population. Thank you.